Welcome to the EKG Club. It's case number 3. Let's dive right straight into it. So this is the ECG. 27-year-old active female with fever and cough 2 weeks ago. Otherwise, she's asymptomatic at rest, vitally stable at presentation, structurally normal heart on the echocardiogram. What is the most likely ECG diagnosis? A. Normal sinus rhythm. B. Atrial tachycardia. C. Atrial escape rhythm with first degree AV block. And D. Sinus rhythm with first degree AV block. So you've got 30 seconds to have a little look at the ECG. So the correct answer is sinus rhythm with first degree AV block. And let's have a little look what's the reason for all of this. So why is it not just simply normal sinus rhythm? Well, one might argue that look at the rate first, look at the calibration. Calibration is standard, 25 millimeters per second is the speed of the paper, and so that's standard calibration. Now looking at the rate, we've got three large boxes which will estimate to around about just a wee bit more than that. It will estimate to around about 90 and between 100 the heart rate. So with this, yes, it is normal sinus rhythm, but is this the only best answer that's available? Because we can now clearly see that if the rate is normal, it's narrow complexes. Look at the P wave morphology, looks absolutely upright in lead 2 and in the inferior leads, but at the same time there seems to be a unusual interval, which is the PR interval. PP intervals are constant, and obviously the PR interval is prolonged. It's more than one large square, almost estimating to almost about 280 milliseconds. So with this, it's very unlikely to be only normal sinus rhythm, so it would be sinus rhythm first degree AV block. Atrial tachycardia, it's not the case because the rate is not in the tachycardia domain, it's less than 100, whereas in an atrial escape rhythm with first degree AV block, again what we see are basically P waves which are upright normal, and then it becomes very unlikely at this rate it will be an atrial escape rhythm. It would be an escape rhythm if it was less than 60 or for the given age, it was less than the normal in that. So in the same patient, this is another ECG where things are slightly different, but let's go through the scenario so that we can discuss this. We've got a 27-year-old same female with the fever and cough that we just discussed in this previous case, but this time she's having dyspnea on exertion. So at rest she was actually asymptomatic, but when she started exerting she started having dyspnea, and this EKG was done immediately after the exertion. Hemodynamically she was fine, and there were no abnormalities detected during exertion. Structurally, as already mentioned, she's got a normal heart, her BMI is normal, TSH is normal, and hemoglobin are normal as well. So based on the ECG, what is the likely reason for her dyspnea? A, is it physical deconditioning, pericardial effusion, pseudo-pacemaker syndrome, or atrial tachycardia? So you've got 30 seconds to actually look at the ECG and decide. What's the correct answer? It's pseudo-pacemaker syndrome. So let's look at a reason what's happening over here. So obviously it's the same patient as in the first case. What we've got is narrow complex regular rhythm. Again, now the rate's almost touching about 100. Again, you can see that the PR interval is grossly prolonged. And to be specific, you can see the P waves. Now these are marked by these arrowheads over here, and these P waves are actually merged in with the T wave, so they can form somewhat like a camel hump. So that means the ventricles, they've not fully repolarized, whilst the atrial depolarization that has started, and so there may well be an overlap of ventricular relaxation and atrial contraction. Although in the normal situation, you might recall that there is always a normal isoelectric line between the T and the P. That's called the TP segment. That allows for the ventricles to fully relax before the atrial depolarization, and then the atrial depolarization causes the atrial contraction. So it allows for adequate and synchronized atrial ventricular filling by the contraction of the atria. However, here the P waves, because they're merged and there's literally obliteration of the TP interval, so therefore there wouldn't be enough time for the ventricles to relax where the atria is actually contracted, and that will give rise to some raised atrial pressures, whether in the right or the left. So raising that and always affecting the Frank Starling forces rate and reducing possibly the pulmonary vasculature area, surface area, for the gaseous exchange of the oxygen with the vasculature. So at the same time, why is it not atrial tachycardia that we're labeling? Because in the last one we said, well, look, if it goes beyond 100, it may be in the atrial tachycardia situation. Here, the PR intervals, as you can see, marked by the green, these are specifically of the same duration. However, these PR intervals are actually of a different duration. At the same time, the P2P intervals, whether they're the red, the purple, or the yellow, they all are varying. So usually in atrial tachycardia, because there's a microcircuit, the PP intervals are very constant. PR intervals usually are very constant as well, unless there is a vagal autonomic modulation that's occurring. So sometimes, yes, you can have maybe slight PR variation, but P2P should not be variating. Why is it not pericardial effusion? Well, pericardial effusion, as we can see, that in the limb leads, the voltages with the standard calibration and the standard paper speed, the voltages are more than 5 millimeters and obviously more than 0.5 millivolts. So therefore, there doesn't seem to be any significant effusion over there. At the same time, we can see in lead V2 that it's almost 1 millivolt, so 10 small boxes. So obviously it's not a low amplitude ECG. Physical deconditioning, well, we've got the information from the scenario that she is an active female. So really, by the method of exclusion, what we've got left is pseudo pacemaker syndrome. I hope this actually proves useful. Thank you for watching, and please subscribe to the channel and stay connected for further ECGs as well.